diabetes are on the rise. About 1 in 3 U.S. adults, an estimated 68 million, have high blood pressure, which increases the risk for heart disease and stroke. Leading causes of death in the United States. That's from the CDC 2012. Do you know what your numbers are? There are only 7 years left to achieve our goals for Heritage in 2020. As part of that move to improve and advance towards improving the number of healthy people, Dr. Chiquito mentioned preventive care practices offering free blood sugar, free blood pressure, free weight, free height, free physical exams, free body mass index, free counseling for depression and mood disorders, and for sexual abuse, and also recruiting interested healthcare professionals and non-professionals to canvass churches and schools to measure blood pressure, blood sugar, weight, height, and BMI. Experience is not necessary and I'm willing to train. I can be reached at my email drchikico1@gmail.com, my Facebook ID, which is Chinyere Ugorji, my Twitter ID, which is drchikico1, and my LinkedIn ID.
I'm Dr. Chinyere Ugorji, 2007 graduate of American International School of Medicine, with 10 years of clinical experience working as a certified nurse aide at various hospitals, long-term acute care facilities, nursing homes, from doing my clinical rotations here in the United States, from various externships and observerships, from 2 graduate medical education programs and referred internal medicine residency programs in Detroit, Michigan, Springfield Family Medicine Residency Program, Springfield, Illinois, from with research experience from UT Southwest and working with Dr. Caronas and Jada Downs, who are both awesome people, and with a master's in business administration with an emphasis on public administration from Davenport University, Grand Rapids, Michigan, and currently working in preventive care, patient education, and mentoring of healthcare professionals with my Ustream on my Ustream show, on my Ustream channel, which is Dr. Chiquito One. My YouTube channel is also Dr. Chiquito One. And in counseling on victims of depression and sexual violence, which I haven't experienced, but motivated by patients acting in my practice. And I'm presenting today on Dr. Chiquito Mentoring Ustream show, and I want to welcome you to Dr. Chiquito Mentoring Ustream show, broadcasting on diabetic ketoacidosis live on Dr. Chiquito One. I want to thank everybody who has logged in. I don't see anybody who has logged in, but if you have, don't hesitate to ask me any questions. I have some questions that are on my website and also a video, which are also on my social media, that are designed to create awareness about some trending topics in diabetic ketoacidosis. This is a very interesting topic. I also have my videos on all my social networks, and I want to invite you to check it out. Even as we go along, check it out. It's on all my social networks, and you can be able to ask me a question. And I welcome any questions via social network, via phone, via email, and I'll make sure that I get back to you with the answers. So today we're talking about well, first of all, why do I do this? I'm just going to talk a little bit about that. Why do I choose to see patients? Why do I choose to become a physician? Well, because the brain actually is a powerful tool for creating the future. The stethoscope is actually an astute diagnostic tool, and the book is actually the final puzzle in creating education. So the book is indispensable. So why did I choose to become a physician? Maybe because I was born a leader. Maybe because I think I like helping people. Maybe because I think it makes me cool. Maybe because I think I can be a source of succor, a balm in the midst of disease, poverty, and mental anguish. To be a physician, you have to have a sincere love for people and a sincere desire to help people. My journey in medicine started when I entered medical school among the first 10 people who was admitted into Ugorji State University. And there I discovered that the knowledge in books could magically be transformed into expertise in the issues of healthcare. I also participated in educational and preventive health fairs. My passion for preventive care started then. migrating to the United States to be with family, I loved ice due to my love for medicine. I went back to American International School of Medicine where I graduated as PhD, Magna Cum Laude, 2009. I mastered my National Medicine Residency Program. My first job after interviewing at 21 Graduate Medical Educational Program. For 2009, I had to leave the program because my clinical skills were rusty after being out of school for a couple of years. So after that, I actually completed 3 months of inpatient rotation and outpatient rotation, working closely with the program director, Dr. Kimberly Baker Jibor, and internist in internal medicine and Dr. Alvin Bowles, a pulmonologist in pulmonary medicine and prescription medicine. And my clinical acumen improved tremendously during the time I spent on the program. So after that, after I left the program, I continued my master's in business administration with an emphasis on public administration at Diabetic University. And I got some hands-on experience working with Dr. Chinyere, a program director emeritus for the family medicine and pediatrics in her private practice in close proximity to St. Elizabeth Family Medicine residency program in Chicago, Illinois, where I was opportune to attend grand rounds and morning report with the residents. 2011, I got married and got pregnant, and I had my wonderful 24-month-old son, CJ, or Kingston, a very wonderful young man with a very wonderful personality. And that was actually during an observership at Council Family Medicine Residency Program, a very wonderful program with lots of opportunities, very wonderful curriculum, wonderful staff, wonderful residents. And I actually um, marched at Springfield Family Medicine Residency program. That was in 2011, and ended up being pregnant to the surprise of everyone. I can still remember the look on their faces when they saw that I was pregnant, and they shared my joy. They shared my condition, and I cried in Springfield Family Medicine Residency program. Um, and my clinical acumen improved tremendously during the time that I spent in 1 year that I spent in the Springfield Family Medicine Residency program, working with the expert faculty, residents, and staff of Springfield Family Medicine Residency program. I also had my baby PJ in supportive atmosphere of Springfield Family Medicine Residency program. I struggled with it, and also my clinical acumen also improved tremendously, like I said, and I also loved to talk from the beginning exam to use Dr. Alba's lexicon. I struggled with residency due to my complex family dynamics, and I had to leave the program. And that was after a frank discussion with Dr. Alban, and after a neuropsychology test that was done that was questionable. And after that, I went back to school for my master's in business administration, which I just finished last fall. And also attended the American Academy of Family Physicians Conference in Kansas City, the American Academy of Family Physicians Assembly in Philadelphia, the American Conference of Physicians Conference in San Francisco. And and I was motivated by advocacy in action. His main focus is to be motivated, highly motivated, experienced, and hardworking residents and medical students, and graduate medical education, and graduate medical students, multiple chances in graduate medical education. So my experiences thus far has taught me that emotional stability, hard work, and um, and um, and and collaborative teamwork will take you wherever you want to go. Um, and since I have finished, I have gotten some research experience with Dr. Cameron and Dr. Lena Downs at UT Southwestern. The programs are very wonderfully organized, great, great faculty, great residents, great lectures, great curriculum, and also a great environment for learning. And and I probably talk too much because I asked a whole lot of questions and very well. And then also, I've also got finished my master's in business administration. I've also initiated some research projects. I've also finished my capstone project on the mental and psychological effects of and the financial involvement on communities in the aftermath of natural disasters. And this was actually done because of some interest that I've had in some of the many natural disasters that have occurred. And this actually answers some questions. I have that on my webpage. You can check it out. My plans for the future include doing an observership or an externship in a program prior to um, doing my residency in a program. I'm working hard in a graduate medical education and residency program, includes with dedicated faculty, residents, patients, and staff in a collaborative environment to help improve healthcare, which has grown tremendously in recent years. My strengths include my interest in education, my preventive care interest, my creativity, my research experience, my interest in psychiatric disorders, and also my persistence. My weaknesses, I would say, include 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 some of the choices I've made in my career, which has led to my inability to finish graduate medical education. But I'm hoping I can be able to do that in the future. It serves as sense as a hope to in faculty in Prince Family Medicine residency as a host. And I apologize. I'm not gonna mention names, but everything was written down. In 10 years, I see myself in primary care in as a hospitalist with lots of obstetric and administrative um, um, stuff. I actually like to work hard, and I like being able to have that exposure, which can occur even if you are trained in a primary care setting. I love challenges. Then my regrets actually I already talked about that, and then I love challenges and I'm much mature and the things that attract challenges, but I've learned that emotional stability, hard work and leadership will take you wherever, and collaborative team will take you wherever you want to go, and has actually helped me overcome serious challenges. Communication is the key to handling confrontations. That is response to how do I handle confrontations. And I have handled confrontations in the past, developing a good understanding of the team members' personality, um, perspective, and the role of the team member in the team. Um, Primary care, working in a basic practice, and having some hospitalist roles, lots of obstetric and administrative roles is what I envision myself doing. And my heroes include people who have contributed towards healthcare reform and patient safety in recent times. I love Zumba dancing, and I'm trying hard to master that with the help of my Zumba instructors and charity work. I'm doing the night walk, the walk for the senior reformer, and also spending time with family and friends. And I'm working on various projects, curriculum review. I'm working on preventive care. I have a preventive care fair coming up soon, and all this is actually on my website. You can go and check it out. So today I'm talking about diabetic ketoacidosis. What do you need to know about diabetic ketoacidosis? I have a case study which I'm going to go through. Um, it's 7:16 into the show, and it's actually in the emergency room. So you are in the emergency room, and a patient walks in. A 20-year-old woman walks in with a chief complaint of vomiting and abdominal pain. A chief complaint vomiting and abdominal pain. So, what do I want to know at this point? I have some series of questions which you have to ask when somebody comes in with vomiting and abdominal pain. So, I'm going to go over those questions right here. So if somebody comes in with vomiting and abdominal pain, what do you do? What do you ask the person? Well, for nausea, you want to ask, do you feel nauseated? Do you feel sick to your stomach? That way you can be able to convey the question. And then also, you also want to ask, did you vomit? Or you want to ask, did you throw up? You want to ask, what color was the vomit? You want to ask, did you see any blood in it? So with that, you can be able to elicit the answers that you need. For pain, for any kind of pain, you have to ask, do you have pain? When did it start? How long have you had this pain? How long does it last? How often does it come up? Where do you feel the pain? Can you show me where exactly it is? Does the pain travel anywhere? Can you describe it for me? Is it a sharp, dull, burning, or taking cramping or pressure-like pain? Is it constant or does it come and go? On a scale of 1 to 10, with 10 being the worst, how would you rate your pain? What brings the pain on? Do you know what causes the pain to start? Does anything make the pain better? Does anything make it worse? Have you had similar pain before? So that's how you ask for questions of pain. That's how you elicit the symptoms of pain. Now, so this young lady that just came in with a chief complaint of vomiting and abdominal pain. So what questions do you want to ask her? We already went through that. So let's get the rest of her history. So she's a 20-year-old woman that presents in the emergency room with 5 episodes of non-bloody vomiting, a 4/10 constant non-radiating abdominal pain that has no aggravating or relieving factors, which weakness and increasing drowsiness of 1 day duration, and increased thirst and increased urination. Um, so 20-year-old woman presents to the ER with 5 episodes of non-bloody vomiting, 4 to 5/10 abdominal constant non-radiating abdominal pain with no aggravating or relieving factors. Um, weakness, increasing drowsiness, increased thirst, and increased urination um, for the past 2 months. So next thing that we want to know is past medical history. What's her past medical history? Well, she actually has the past medical history of, she actually has no past medical history. So past medical history, none. Past surgical history, she has no past surgical history. Um, family history. And to get a family history, what questions do you ask? I'm going to go over that in a minute. So to get a family history, the questions that you ask include, does anybody in your family have the same problem or anything similar? Are your parents alive? Are they in good health? What did your mother or father die of? Are your brothers or sisters alive? Are they in good health? So that's how you get a family history. So that's actually how you get the family history. So um, I'm gonna go over how to get all the history, but that's actually something that I'm gonna be stressing on within the next few weeks. So family history, how do you get that? Social history, how do you get that? Medication, allergies, how do you get all of that? Um, so for the family history, we just talked about that. What questions to ask. So for the social history, what questions do you want to ask in social history? In social history, well, you want to ask, do you smoke? How many packs a day do you smoke? How long have you been smoking? Do you drink alcohol? What do you drink? How much do you drink a week? Do you use any illegal drugs? Which ones do you use? How often do you use them? Do you smoke or inject them? What type of one do you do? Where do you live? With whom? Tell me about your life at home. Are you married? Do you have any children? Do you have a lot of stressful situations on your job? Are you exposed to environmental hazards on your job? And that also includes an alcohol history too. We want to know how much alcohol do you drink? How about, tell me about your use of alcohol. Have you ever had a drinking problem? When was your last drink? Then you administer the case questionnaire. Have you ever felt the need to cut down on drinking? Have you ever felt annoyed and criticism of the drinking? Have you ever had guilty feelings about drinking? Have you ever had a drink first thing in the morning? I don't do that. Steady your nerves and get rid of your hangover. Um, then for the sexual history, which is also part of the social history, I want to ask, I would like to ask you some questions about your sexual health and prostate. Are you sexually active? Do you use condoms always? Other contraceptives? Are you sexually active with men, women, or both? How many sexual partners have you had in the last year? Do you currently have one partner or more than one? Have you ever had an STD? Do you have any problems with sexual function? Do you have any problems with erections? Do you use any contraception? Have you ever been tested for HIV? So those are the questions that you are going to ask. Um, so those are the questions that you are going to ask for the social history. At this point, looking at the rest of the answers that we have from the patient who is sitting over here, and you have to, of course, introduce yourself to the patient. You have to make him feel comfortable. You have to ask him, tell him, hey, Miss, Mr. Smith, hey, Mr. Smith, I'm gonna be asking you some questions and doing a physical examination. I hope that's okay with you. And of course, you have to make sure you receive consent from him to be able to do all you're supposed to do. So the rest of the history of physical examination. Um, so um, for past medical history, she has no past medical history, family history. She has a family history positive for type 1 diabetes mellitus. Her father, paternal uncle, grandfather are all diabetic. Um, social history. Social history, she's not a smoker, she's not an alcoholic. So for occupation, she wants to be as a waitress in a restaurant, or as a certified nurse aide, or as a teacher. She also doesn't drink alcohol. She lives by herself. She does not smoke. She has no illicit drug history and sexual history. She's sexually active with her fiancé, and she's sexually, she uses contraceptives. Um, so that's the rest of that part of the history. So at this point, we want to get a review of system. And how do we do that? We want to get a general, any fever, any malaise. We want to get look at the skin, ask her about any rashes. We want to look at the head, any hair loss, any hair changes, any earaches, any nasal discharge, any throat pain, any problems with the physician, any malodor, her neck, any masses, her breast, any changes in her breast, her respiration, any changes in her respiration, shortness of breath, breathing, you want to get all of that, cardiac, any breathing, any palpitation, any heart problems, GI, you want to ask about any nausea, vomiting, diarrhea, apart from what we elicited earlier. Urinary, you want to ask about any problems in urination, any changes in color of her urine, any odor to urine, any frequency, going to the bathroom a whole lot. You also want to ask about genital, any problems in genitalia, also about her vascular, any problems with her vascular system, any swollen legs, musculoskeletal, any aches, arthritis, neurological, any problems with vision, any headaches, hematological, any swollen lymph nodes, any night sweats, and then also endocrine. That's what I asked about that. That's also part of endocrine. Hematological, we already talked about that. So any fatigue, weakness, swollen lymph nodes, psychiatric, any mood changes, any mood disorder, blurry vision, acute bleeding, easy bruising, indigestion, dysphagia, changes in bowel movement, bloody stool, morning or urination, recent travel, ill contact, vaginal discharge or itch, pregnancy, heat or cold intolerance, drug or alcohol use, her last menstrual period. And because she's female, you also want to ask about that, especially since she has vomiting. You're thinking that she could be pregnant, so you want to ask about that. So I did not include that, but that's normally under OBGYN history. So you want to ask about that. So how her menstrual period ended 4 weeks ago, it was normal in duration. Like, how do you elicit a menstrual history? You want to ask about her menarche, what age did she have a period, how often her periods, are they regular every 28 days, has she received any changes in her periods, has she any abnormal bleeding, any change during her periods, so that's how you elicit the menstrual history. Now, at this point, you want to do a physical exam. So what do I want to do? Well, at this point, I want to do the vital signs. We already have a vital signs. But I want to do a general survey. Just going to look at her. So I'm going to bring her on the table. So, hi, Mrs. Smith, Smith, I'm going to do a physical exam. So I'm just going to do a general survey. I'm just going to look around, see if she looks in any acute distress. But first of all, how do we, if she looks in any acute distress. And then also, I'm going to go ahead and tell you what the results are too. So the patient is in mild to moderate abdominal pain and appears very distressed. So for the head, ear, nose, and throat, I'm going to examine the mucous membrane. So here I'm going to, you know, this is not a real patient, so we might not see. So I'm just going to look at her mucous membrane. I will move her eyes like this, look at this, look at it, move her eyes like this. Because what am I looking for? I'm looking to see if there are any dryness in her mucous membrane. And then also, I'm also going to look at her mouth. So I'll ask her to open her mouth, just shine a torchlight to look at her eyes to see if there's any constriction and if she has good iris edge. And then also I'm going to look at her throat. So I'm going to just look at her, I'm going to open her mouth and look for, I look at her mucous membrane, make sure that she's not dehydrated. And then also, I'm also going to look at her neck. I'm going to examine her neck to see if she has any swollen lymph nodes. I don't have to look at her ears, and that's all I'm going to do for the head, ear, nose, and throat, and for the mouth too. So at this point, I'm just going to now, also check for any extraocular movement, because I mean, if she appears distressed, she might have some neurological dysfunction. So I'm going to ask her to just follow my hands. I'm going to ask her to, I'm going to go up, go to the side, go to the side, go to the side, go up, go to the side, go to the side, and then I'm going to check for any surgery. So, and then after that, I'm going to listen to the lungs. So how do I do that? I'm going to get at my stethoscope. I'm going to tell her, hey, Miss Smith, I'm going to listen to your lungs. And she'll be like, okay, that's fine. Of course, I have to make sure that she's appropriately braced. So I'm going to ask her to sit down. Normally, I like to listen to my patient's lungs with them sitting up and then also with them lying down too, depending on what I want her to say. So I'm going to ask her to sit up, and then I'll listen to her lungs. Now, before I listen to the lungs, what do I tell her? I need to tell her, I'm going to listen to your lungs. I want you to just take deep breaths in and out. That way she will know. So I'll listen to the anterior and the posterior lungs. So I'm going to listen to your lungs. I'm going to listen to the anterior and the posterior lungs. So that's how you listen to the anterior and to the posterior lungs. And also, sometimes I also want to have her lie down when I listen to her anterior and her posterior lungs too. So I'm going to ask her to lie down. I'm going to now I'm listening to her lungs. At this point, I want to listen to her heart. And I want to listen in two positions. I want to have her to sit up and then also to lie on her side. So I'm going to listen to her heart. So I'm just going to listen in the aortic, in the pulmonary, in the mitral, in the aortic, pulmonary, in the tricuspid, and then also in the mitral. So in those four places. And then I also listen to her heart. I'm not going to do any specialized maneuvers. I'll probably want to listen to the mitral with her lying to the side. Just to make sure that I have I can hear the effects very well. But that's it. Since it's an emergency situation. So I'm listening to the aortic, I'm listening to the pulmonary, I'm listening to the tricuspid, and then to the mitral. Okay, and then I'll ask her to lie to her side, and then I'll listen to the mitral in her head. And that's listening for the effects of the heart. So at this point, I want to do an abdominal exam, which is actually pretty close to, doing a thorough physical exam. So first of all, I'm going to ask her to lie down and make sure that she's dressed appropriately. I'm going to ask her to lie down. I'm going to examine her stomach. I'm going to see if there are any obvious palpitations. So I don't see any. Of course, it's on a live patient. And then after that, I'm going to listen. It's very good to listen. It's recommended to listen before you start any palpation, because you can actually raise some straight fall sounds by palpating before listening. So I'm gonna just listen to see what her bowel sounds like. So I'm gonna get this. So how do you listen to an abdominal sound? Well, you listen by listening in all four quadrants. You listen in the upper outer, in the right upper quadrant, left upper quadrant, right lower, left lower, and then right lower quadrant. So that's how I listen to the abdomen. And then after that, I'm gonna do the palpation. So I would gonna palpate. I'll tell her, Miss Smith, I'm gonna push on your stomach, and you have to elicit consent all the time. So I'm gonna push. Looking first of all, I'm gonna make sure that she doesn't have any pain as I'm doing that. And I also tell her, if you have any pain, just let me know where and when, and I can be able to stop. So I'm gonna push, 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 push. Now for palpation, you have the light and then the deep palpation. So for the light palpation, you just gonna rub again the stomach, not pushing very deeply, the four quadrants. And then for the deep palpation, you're checking for the organs. So that way you're gonna just push, push, check for any organomegaly. So that's how I do the abdominal exam. And then also, I wouldn't want to palpate because I don't think there's any organomegaly. I wouldn't want to percuss, I'm sorry. And it's an emergency situation, so I wouldn't want to percuss. But doing a full abdominal examination, you have to percuss. After palpation, you have to percuss. And how do you percuss? You just get your finger and then you pull at the top. So percuss, 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 percuss. So that's how you can talk. It's all the four quadrants. So that's infection, auscultation, palpation, percussion, and then also checking for organomegaly. So that's all the aspects of the abdominal exam. You might want to do all of them on how, depending on how fast you are. But this is an emergent case, so you want to start emergent order immediately. Now, also, I want to do an extremity, an examination of her extremities. I want to check. So, Miss Smith, I'm going to tell her, Miss Smith, I want to check your extremities. So, I'm going to ask her to sit up. Normally, I just sit up with their legs dangling down, and then I'm going to look for any edema, any swelling. I'm going to check the pulses. that's actually it for the lower for the extremities. Um, so the results of the examination. General, she's mild to moderate abdominal pain and appears very distressed. Um, head, eye, ears, and throat. She has very dry mucous membrane. No JBB, extraocular movements are intact. Breast is unremarkable. Lungs, flesh, or conditions are naturally. Heart, completely normal except tachycardia. She has some tachycardia, which could be due to due to dehydration. Abdomen soft, non-tender, no mobile sounds with, and no guarding or rigidity. Extremities, no edema, scalp tenderness, but weak peripheral pulses. So, her extremity, she actually has some weak peripheral pulses. Now at this point, we've done the physical examination. So now at this point, we have to come up with an assessment and plan. What do we do? Now, my normal algorithm is to say, is this urgent or not? Is this emergent or not? It's emergent. You don't need to include the physical exam, which you just did, a thorough physical exam. I have come up with a differential diagnosis. So what are my differential diagnosis? Well, I'm thinking it could be of abdominal pathology. It could be something like appendicitis, gastroenteritis, it could be pancreatitis, it could be acute intestinal obstruction. It could also be pregnancy, or it could be due to menstrual symptoms. It could also be due to diabetic ketoacidosis. It could also be due to non-ketotic hyperosmolar state. It could also be due to alcoholic ketoacidosis, even though she's not an alcoholic. It could also be due to drug intoxication. So those are my running differentials. So what do I want to order? I want to order a pulse oximetry, start and continuous. I want to order an oxygen inhalation continuous. I want to order IVF start. I want to order a cardiac monitor start. I want to order normal saline, 0.9% normal saline continuous. But she's fatty, she's tachycardic, so she could actually be dehydrated. So she needs IV. And then also she also needs finger stick glucose start. So the results, and then also some other tests that I'm going to need to order include a urine pregnancy test. That's actually top of my list because she could be pregnant. She's sexually active. A sexually active female that comes into your office with nausea and vomiting, pregnancy test should be number one on your list of orders. A CBC with differential start, a BNP start, a calcium serum start, an EKG 12 lead start, serum amylase start, serum lipase start. What am I looking for with serum amylase and lipase? I'm looking for pancreatitis. A UA start, ABG start, serum osmolality start, serum ketose, polypeptide start, regular insulin, IV continuous, Senegal, IV one time for nausea, and then also stop the oxygen at some point. So how much Senegal do I give her? Normally Senegal, we normally give dosing is actually very important in Senegal because it becomes IV and also in PO and also PR mode. But a patient in the emergency room, she needs IV Senegal for starters, and then later on you can change it to CO. So Senegal, which is also called promethazine, is actually a very efficacious drug. And it's actually an antihistamine, 10th generation antihistamine, and anti-emetic agent. So it comes in 12.5, 25, and 50. That would probably want to start with 25 milligrams IV every 4 to 6 hours, and then later on I can transition to 25 milligrams PO because she has some severe nausea and vomiting. So that's where we are right now. So the result of the test that we just did, the pulse oximetry was 96% on room air. I think that glucose shows 600 milligrams milligrams a year. So she does have diabetic ketoacidosis. The urine pregnancy test was negative. Her white blood cell was 10,000 and normal differential. Sodium 129, potassium 5.0, chloride 90, CO2 was 14, calcium 8.0, blood sugar 600. EKG was sinus tachycardia and that's it. Serum amylase was mildly elevated. Serum lipase was within normal limit. UA showed 4 plus sugar 2 plus ketones was not evidence of infection. Serum osmolality was 305, serum ketones was high. ABG showed that metabolic acidosis compensated by respiratory acidosis pH of 7.3. So with these results, my learning differential is diabetic ketoacidosis. So number one, I'm looking at plan is what diabetic ketoacidosis because I'm writing my notes. I'm going to be doing a session on note writing coming up on my people next show and also from next week when I'm going to have the virtual ground round. So number one is for my assessment and plan. Number one is what diabetic ketoacidosis. And I'm going to walk through how to treat that, how to handle that, the treatment modality. Also vomiting. We are going to we just have Senegal 25 milligram IV, which is transition to 25 milligram PO when she stops vomiting. I want to start tolerating and PO intake. Abdominal pain. Some Tylenol. We fix that 500 milligrams PO every 12 hours or every 68 hours. And then preventive care and counseling. So those are my assessment and plan. So for her diabetic ketoacidosis, well, she needs to be in the ICU. Then we need to order an NPO, bed rest, vitals as per ICU protocol, which is normally every 2 hours. Urine output, potassium chloride IV continuously delivered, A1C level routine, phosphorus serum routine, and then order a BNP every 24 hours and every 8 to 12 hours, and then every day. That's how you do it till she gets discharged. An ABG every 2 hours, twice. If you want to do it twice, make sure she has no acidosis or alkalosis. And then after 4 hours, you stop the normal saline and then give her half normal saline. So that's good management for diabetic ketoacidosis. Then you also have to monitor her potassium because potassium deficiency actually happens a whole lot in diabetic ketoacidosis. And then also consider antibiotics to if it's an infection. And how do you know it's an infection? If you suspect an infection, if she has a fever, she did not have a fever. Her vital signs were actually temperature was 100. So she had a slight fever, but if she continues to fight the fever, normally I would just go ahead and order a chest X-ray. I would go ahead and order blood cultures, UA and urine cultures. So that's just kind of regular for what I would order. And then once she stops vomiting, like we talked about, vomiting number 2 on the particular plan, we are going to start her on oral fluid. And then once she's stabilized, we transition her to the water for the 12. So during discharge, and about fluid management and insulin management for diabetic ketoacidosis, once her blood sugar comes down to 250 after the first 3 to 4 hours, you should change her fluid to half normal saline. So that's actually very important. And she actually needs to be on IV insulin till when she gets discharged, and then we start her on an insulin regimen. That's something that we'll talk about too, coming up soon. And the infant toolkit. How do you manage fluid replacement and also insulin dosage? Very important. So for discharge, you have to distribute the IV insulin, start NPH insulin, subcutaneous continuous. Also start regular insulin, subcutaneous continuous. You have to start both of them. The regular insulin actually has a shorter half-life. The NPH is actually has a longer half-life, and you have to dose it so that give her the appropriate dosing and tell her when to take it. And then also you also have to do diabetic education. Most hospitals have a good diabetic education team, and you can teach her how to take her blood sugar. Normally, it depends on how you want to do it, but Patient education is very important. Home glucose monitoring is very important. No alcohol, that's under preventive care counseling. So no alcohol, no smoking, safe sex, no illegal drug use, regular exercise, seat belt use. It's actually very important. And when do I want to see her back? I want to see her back in 10 days. That's actually pretty important. Now, for insulin dosing, normally start with an initial bolus of 10 to 15 minutes of regular insulin with a continuous infusion at a rate of 8 to 15 units per hour. And then when her glucose level begins to approach 250, like I mentioned earlier, that's when you now change the fluid composition to include 5 to 10% dextrose, and that's to avoid hypoglycemia. Yeah, so I'm going to have all of that in the instant toolkit coming out, and for the chest x-rays like EKG, you can always look at the presentation on the website. Assessment and plan, number one, diabetic ketoacidosis. How do you code for that? I mean, with ICD 10 coming up soon, that's actually pretty important. So how do you code for um, for diabetic ketoacidosis? Well, it's 250.1. That's how you code for diabetic ketoacidosis. So our working differential today is diabetic ketoacidosis. We don't have to handle that. Vomiting, we don't have to handle that. Abdominal, we don't have to handle that. So I'm gonna briefly go through the healthcare news from Baker Fine. The top story is CMS ways when how to disclose individual physician Medicare pay. So physician remuneration is actually pretty pretty huge in the news right now. It's trending in the news. So that's something that we have to watch out for. From their Facebook page. I'm going to also bring you updates from all the organizations and from their Facebook page. From the American Academy of Family Physicians, we still have some trending articles, which include common sleep disorders, childhood eye examination, parathyroid disorders. Very interesting articles. Please check it out. And also they have articles from their past issues. So check that out. Um, and also the Choosing Wisely campaign is actually, creating lots of waves in patient population. So check it out. Check it out, folks. From the from ACP, the American College of Physicians website. We are minutes towards the end of the show, and I'm bringing you healthcare news. There are so many advances in healthcare which I want to keep you up to date on the Portuguese Fermenting Newsroom show, and we are gonna go through these real quick, and I will talk about some announcements. Thanks to my sponsors, and talk about my work for the Chinyere lymphoma. So we are probably going to end like 8:15. I want to thank you for your patience, and don't hesitate to ask any questions. So from the American College of Physicians website, clinical information, very, very nice articles, running in practice, education and use certification, residents and fellows, they have a lot of interesting resources for them, and medical students too, there are also lots of interesting resources. The NK sub question of the week for residents is actually on is actually pretty interesting, and I'm probably gonna go through that in a minute as I'm going to the so I'm pulling up the MCSAP question of the week. With the internal medicine review, is an exam coming up. I'm pretty sure that a lot of you are actually reviewing your MCSAP. The ACP has very interesting interesting articles on from and also the MCSAP questions are very good for for reviews. And they have this ongoing feature called the MCSAP question of the week. And I actually am gonna post a very useful article that I actually found about that particular topic. So I'm gonna let you know exactly where to find that resource. That resource. The MK question of the of the week. I'm gonna actually post an article on that topic, and you can always access the resource on their website and answer the questions as it comes out, and that will actually help you with studying. I'm gonna also have a review session too coming up soon. On MTSAP, so that is actually very important. I'm probably going to talk about that before the end of the show. I apologize for that. So from the IHI, they have a lot of upcoming conferences. The ACP Forum coming up in New Zealand. The National Forum on Policy Improvement coming up in Orlando, Florida in December. And also the one in Washington, D.C. on improving patient care in the office practice and in the community. That's actually March 2019. Um, from the Society of Teachers of Family Medicine, they have a call for applications for resident categorization toolkit task force. So that's actually trending from the Society of Teachers of Family Medicine. Um, some other organizations that some other healthcare organizations that also have trending developments include the American Medical Association, and healthcare is actually a very fascinating field with lots of developments, and so the top news and articles include small doctor groups using IPA to deliver care management, and also a program for improved blood pressure control. The NCP actually has a very good article for blood pressure control. So check all of that out at Dr. Hogan in the news. She's on the road. So on the road with Dr. Hogan, check that out. Um, from the American Psychology Association, the Physician Sunshine Act is actually in the news. So check that out. And also, teens, are they typical of trouble? That's something that we also need to know about. And that's all on their website. From the American Psychology Association, from the American Psychiatric Association, um, trending in the news on their website includes from the American Psychology Association, trending in the news, includes from the American Psychology Association, from the American Psychiatric Association includes the Sunshine Act and also Teens, Typical of Trouble. Very interesting article. I do a lot of counseling, and that's actually something that is actually pretty pretty interesting. So, American Psychological Association, trouble staying focused in school. ADHD is actually in the news recently, ready for takeoff. Never a dull moment. So these are all interesting articles, interesting features that you can actually take advantage of. From the World Health Organization, the first pre-qualified medicine to treat the neglected tropical disease. That's actually talking about the medication for idiopathic ciliaritis. That was actually featured as a question on one of actually it was a differential on one of the questions on the New England Journal of Medicine Image Challenge of the Age. That was 2 days ago. And the medication we're talking about is diethylcarbamazepine. So that's the medication that we're talking about. And the Director General also has features on the website. So you can check that out from the British Medical Journal. Use of antidepressants near delivery. I'm into counseling. And pregnancy, postpartum depression. These are all interesting topics that I want you to bring to me. I want you to fill out the questionnaires on my website so I can be able to talk about it with you. I can be able to collect the data for public health organizations. And that's from the British Medical Journal. From the University of Atlanta for Medical Sciences, it's 8:01, so we are running towards the end of the show. They have a question. Why does reducing salt intake help prevent hypertension? Well, because it reduces build up in the body. So that's the answer. I'm gonna update the web page, my Facebook page actually, which is gonna show my web page with all of that, and you can be able to take advantage of that for your educational and reading purposes. Um, so we are up toward the end of the show. I want to thank everybody who has logged in. Please feel free to post a question, answer the poll. The videos, actually has a poll that we can just post an answer on the poll, and it will show up. It comes to me, and I can discuss that with you. I can be able to offer medical education to you, and refer you to the appropriate physician for medical care if needed. And I can be able to offer the preliminary medical care. For my preventive health care health fair coming up soon. I am gonna be doing a lot of interesting stuff. I'm gonna be doing your blood pressure. I'm gonna be doing your blood sugar. I'm gonna be doing your height. I have a very useful tool University of Atlanta for medical services, for medical sciences. We already talked about that, but the definitive answer, which I would say is is that self-intake reduces the fluid buildup in the body. That's how it helps to prevent hypertension. So that's the answer. All this are going to be updated on my webpage. And I want you to take advantage of all the features on my website. Um, the um, the um, the daily scriptures, which are very interesting. CMDA also has interesting stories. We're 806 I think into the show, so I can't really go into great details. And then also the weather. You can know what the weather is wherever you are on my webpage. Also the sports. You can know who is playing from my webpage. So all these are very interesting things that you can take advantage of. Utilizing my webpage. I want to thank my team for live the night walk. If you work for lymphoma and leukemia and lymphoma is a blood disease that causes fatigue, weakness, loss of appetite, weight changes. It also causes death eventually. But because of life-saving research due to your donation, due to donation of people, from people like you, victims have actually been, lives have actually been saved. The Leukemia and Lymphoma Foundation, the National World Foundation has very interesting videos and very interesting stories. And I also invite you to share your stories too on my show to send me your stories so I can be able to share them on my website and on my social media. And that way we can be able to get people to get excited. I want to thank my team, Brian, Brian, um, Downey, Alfie Owona, Yuji Obong, Bessie Klein, Love Untidy, Craig Church, Jimmy Albimbo, Jessica Fokker, Guru Miha. I want to thank all of you. Those who are active, those who are not active. And also we have a new member, Timothy Williams, and I'm going to share his story right away. We are 807 into the show. It's also gonna be on YouTube too, coming up soon. So let me share Timothy Williams' story for joining um, Dr. Chiki's team. I want to invite all of you, my team members, to share your story too. We are trying to get more people to join the team. We're trying to raise awareness about leukemia and lymphoma and to get towards becoming a champion for cures. Funds raised so far is $23. I was able to raise $2 yesterday. And all this is going to be processed and sent to Light the Night One. Fisher and Janet, if you're out there, hey, it will be sent to you by the end of September after it has been processed and the appropriate tax receipt has been given to those who have donated. So let's hear Timothy Williams. Hey Timothy, if you're out there, hi.
This pool party, the health fair and everything, to see how I am. And that's all I got to say about it. But I'm excited.
Okay, well, thanks a whole lot, Timothy. We are glad to have you on our team. You feel good about being part of Dr. Chiquito team for Light the Night Walk,
Yeah.
and being part of the move to help people with leukemia and lymphoma to raise funds. And I look forward to working with you.
Absolutely.
Yeah.
Yeah, so that's Timothy William. And hey, Timothy, I'm gonna have his information updated on my webpage. He will have his own fundraising tools, and you can be able to join him as he tries to raise funds for creating for becoming a champion for cure. When the countdown begins towards $100, we need to have $100 to have our pictures on his webpage. To also have balloons and become a champion for cure. It's all about making a difference. It's all about raising funds for the senior and lymphoma. I'm gonna do the Zumba move of the day. We've gone over some Zumba moves, and so on Monday we talked about doing this. So that's bend your hand, shake, bend your hand, shake, and shake, shake. Then number two, on um on Tuesday we did this. So this, and then on Wednesday, no, that was on Wednesday. So we've done two Zumba moves. We did Tuesday and Wednesday. And that was this, and then this. So today, our Zumba move for today is gonna be we're gonna walk, and I'll do that walk, and then we go back. One and two. So walk, and then back. So that's it. So let's just do what we have done real quick. We are all aiming towards Saturday when we're gonna do the routine. It's complicated, but we're gonna have fun. Please log in. So so that's it for today. And so three rules, and then I'm gonna have us listen. I'm gonna play this song for my team. Brian, 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 all the teams, all the members out there who have their fundraising pages, which I want you to put to good use. You rock. I'm gonna play this song for you, and I want to wish you a wonderful day. So challenge yourself. Go up to your team members at work, go up to your friends and family, challenge your kids. They are still at home and they are all daring to come to that preventive health care party. Challenge them to this dance, get them to become more active, get them to raise funds for the people. So I want us to get $100 before the end of this month. And so I'm gonna play this song for you. You won't regret being a part of this work for the people. If you eventually sign up, you are gonna be part of a good move, part of a good cause. You will feel good about it. I felt good about it. I worked last year. I didn't have a team, but this year I have a team. It's very wonderful team. Who have been raising funds, and I want to challenge all of you to become part of this. Come on, actually start by being part of my team. You can send me an email. You can post on my wall. I can sign you up, and you have your own fundraising team. You come part of our activities, come part of the show. You are even free to call it. I'm gonna do a call and come Saturday. So I'm gonna call everybody on the team on Saturday during the show, and we'll talk about it. You wanna create an active participation in this thing and be able to raise funds and you feel good about it. I want to thank all of you. It's all about you. It's all about making a difference. It's all about making a difference in the lives of those who are missing on the summer. So thank you and have a wonderful day.
You make the world.
And I want to thank all my sponsors from the AFC conference, from all the conferences I've actually attended. You have actually invested in my education. I want to thank you, the UPMC Family Medicine, the Toledo Hospital Family Medicine. I have a hand sanitizer from them. I have a pen light too from them. I have this heart sound that tells me about the timing of basic heart sounds, the physical findings, actually got this from a resident. I actually have this pen from ACT. I actually have this pen from traditional physicians booklet, family medicine obstetrics. And I also have this cup holder from Union Hospital Family Medicine Residency, along with a tape measurement. And I have a coffee cup and a CD, very interesting CD about the features of the program. And I also have a flashlight too from Union Hospital. Trying to hold up Union Hospital. I hope I become a good fit for your program and I end up at your program. I also have this from our Solar Family Physician. Trying to hold up. I want to have your pictures on my webpage so I can be able to attract people to be able to be part of my team. I also want to thank St. Joseph's Health Center. They gave me this hand sanitizer. Pomona Valley Hospital, that's in California. Family Medicine Residency Program. I have some names from them. I also have a badge from DVMC Family Medicine Research Program. That's a whole lot. That's Pomona Valley Medical Center. I also have CMS. That's a whole lot. We're talking about calling ICD-10, and they have all these offerings that they offer. I also have Family Interest Group. Actually, Berkeley. You guys packages. I'm gonna be getting back to you about new family review. I'm getting out to all of you guys. Sustainable care, I have epidermica. We're gonna be using that on my show. I'm gonna just click it on here. Um, and then I also have a water bottle from them too. I have a water bottle from them too. You rock, guys. I also have this from Medical Para Familial, Family Medicine Obstetrics. And then I also have this from Hospital Physician Partners. To all of you rock, I want to thank you. And to thank the ladies and the gentlemen from Tower. You are awesome. So thanks a whole lot. You make the world a better place. Have a wonderful day.